questions. Dr. Han and Dr. Kapoor are here. I just forgot to mention, and Dr. Kapoor and Dr. Han are actually our rising stars. So they get new titles every year. I didn't realize Dr. Han was the director of vascular surgery at Morningside. So I'm sorry. All right. So if anybody knows our live cases, we have a lot of fun during our live cases. So go ahead.
Another question. Sometimes we find discrepancy between the symptoms and the investigation. Exaggerated symptoms in mild, moderate, or mild disease, and vice versa. Also, we find sometimes discrepancy between functional tests and anatomical ones. Which parameter we should rely on to determine the need for intervention for such patients? Symptoms, or symptom function, or functional, or anatomical?
It's a great question. I mean, like, listen, all the testing that we do is just to give us an idea of who actually needs an intervention. Ultimately, if the history and your physical exam findings are consistent with someone who needs one, that's probably the way that would actually go. But all that being said, you have to try to figure out. We talked about how, especially ultrasound, is such a technologist-dependent procedure. So if you're unsure about it, go and you actually should take a look at the images yourself and take a look at the actual vessel by yourself. This is why Dr. Sanz's talk would also be very good, because if there was some kind of significant discrepancy between your ABI and something like your duplex ultrasound, a CAT scan does add substantial amount of value. And sometimes when I'm not entirely sure about what's going on, then I will get a secondary imaging modality. Reason why all of this is important, the reason why all of this needs to be set before you go to your intervention is your patient's going to go into your intervention with the expectation you're going to make them better. If you went in and your testing was off from the get-go and you intervene on a lesion that necessarily didn't need to be intervened on, they'll be pissed at you. They're going to come out, I feel exactly the same as I did before, doctor, of what gives. So really, whenever you come to this, is setting expectations about what they actually have and knowing exactly what they have currently.
Yeah, I think that's a great idea.
Anybody else, please?
Thank you, Dr. Han. Regarding venous reflux, do you routinely get the venous ultrasounds on all patients, or only when conservative measures fail, or when you're planning a
Yeah, so for the most part, when patients initially show up, a lot of them, by the time that they do come to your office, I will tell you, the ones that end up in your vascular offices are people who've kind of are coming looking for answers about things, and you can give them an idea. I don't get venous duplexes on everyone, long story short. If they have physical exam findings and things that do look like it does correlate with venous disease, and I will get it. I have a very low threshold to get it, but the patient comes in, and recently I had someone who was like, it really does feel like my feet just feels cold, and I think I have some vein issues. Like if I see a patient like that, I'm not getting a venous duplex. Like that patient's not going to really refer from one. But we talked about the SEEP classification, everything from C1 all the way up to C6, any kind of evidence of that, and I will routinely get it, and I have a very low threshold to get it. What do you do?
No, I think I agree with Dan. I mean, you'll see a lot of patients who've been running around saying, oh, I have kidney problem, that's why I have leg swelling, I'm overweight, that's why I have leg swelling, I have heart failure. So we tend to underdiagnose venous disease as well. So if you have a clinical inclination of, if you suspect a venous insufficiency is adding to the problem, I'm sure there are multiple factors playing in your so-called lower extremity edema, but if your venous insufficiency is adding to the problem, a venous ultrasound definitely gives you a good direction to say, okay, if this is present, it is not present, is it deep venous system, is it superficial? So that way you can at least treat the patient appropriately, conservatively to begin with. And if eventually down the lane, if it's failed conservative therapy in all the fronts, then you can talk about the next steps, whatever it might be, intervention or other higher modalities. But yeah, I mean, keep a low threshold and then treat the patient appropriately.
Can I ask it too, you guys? I mean, so there are certain patients that I get CAT scans on all the time. Are there, like, when do you guys use CTAs?
I was just about to ask you guys that question. So I don't get CAT scan on almost anybody unless I feel like they have a significant iliac disease. I'm suspecting iliac disease, then I do it, or aneurysmal disease. I do it to plan my intervention. I think it's more of a vascular surgery strategy, but I don't think we shall.
Yeah, so again, like Han said, very important. It's your ultrasound technologist you're dependent on. He's your driver for the car, right? So if you rely on your ultrasound guy and it shows, okay, I have a focal SFA stenosis, then CAT scan, I don't think is going to add much value if all the velocities, other waveforms and everything looks good. But if you start seeing monophasic waveforms all the way from your femoral down and it's more suprainguinal lesion, then you're in in a territory where you're planning your suspecting iliac disease and then planning it appropriately, in those cases, CAT scan really gives you a very good idea. Dan and me will discuss a case which we did 2 weeks ago. Well, which whatever. We'll show it to you later on. But the idea is to, especially for iliac disease, you need a good planning, a good thought process to see if it's an endovascular, surgical, and you don't want surprises when you go in. So it's a lot dependent on what you find on your ultrasound or ABIs that will give you a good directionality, whether it's focal, I'll go straight up, or whether it's disease all over and I don't know where to start, where to end.
Yeah, I completely agree. The one person who gets a CAT scan up front, if I have reduced femoral pulses on either side, that patient's getting a CAT
Yep.
scan. The things that you do not want to run into as a surprise is significant aortic lesions or significant iliac lesions when you're trying to do your up and over contralateral intervention. That will add significant complexity. It may change the way that you get access. So I think for me, in my practice, it's mandatory. If a patient has diminished pulses in the femorals, they get a CAT scan. For the lower extremities, because of what Vishal is talking about, at some of the hospitals that I cover, if I don't have a good inpatient ultrasound tech, that person's getting a CT angio with runoffs. But they know that there are limitations. Significant calcification
Correct.
makes it almost impossible for you to figure out what's going on in the tibial vessels. CAT scans notoriously terrible for that. And hopefully we'll get Dr. Sanz to talk about that later. MR, not really practical as an inpatient study. It's very difficult to get. As you know, the patients, the MRs are running 24 hours a day constantly, and to get an inpatient study is almost difficult to do.
Anybody else? I actually have a question for Dr. Han and Vishal, because we don't have a CT MRI talk yet. MR angiography, Vishal and Dan. What do you guys think? When do you think, is it useful in our field, or?
Yeah, I mean, I use it a lot in younger patients, mainly because it gives you so the place where I see MR angiography, not really as a flow study, I don't use it for anything else. But for patients who have any of the other kinds of things that you want to talk about, popliteal entrapment, adventitial cystic disease, something that requires a little bit more evaluation of some of the muscles and things around it, I think young patients will routinely get an MRA rather than getting just a CAT scan. It just gives you so much more definition into the muscle that's surrounding the area.
Oh, yeah. No, I agree with Dan completely. It's just getting the information and the technical aspect of getting an MR, what's your limitation is. But I just have a quick question. How many of you do venous intervention, like deep venous, in your training? Okay. So do you guys treat May Turners? I'm sure you do. How many of you get a CTV or an MRV before May Turners? So almost like half. So Dan, so this is always a controversial, venous disease, a new upcoming, for whatever reason you might call it, with a lot of gray zone area and still a lot of learning as well. So let me ask Dan, because he's the surgery aspect of the whole thing. Role of CTV, MRV in May Turners versus directly going in doing an
Vishal just opened a can of worms.
I love to focus.
Yeah, I think I'm pretty conservative. I get cross-sectional imaging on everybody. I always do, mainly because, once again, I really believe in setting expectations for patients. So if I see significant narrowing on something like a CAT scan and MRV, then I do let them know that it's something that we can potentially go in and treat. If I don't see anything, it doesn't mean that I'll never do an IVUS, because as we know, and as you heard Dr. Sandeep talk about it, the best modality for diagnosing some of these narrowings is going to be your IVUS. But all that being said, I think it's really important for me to set expectations for patients before they go into the procedure. And I think you just need it. I mean, there are some criteria that's coming out now where ultrasound can help you diagnose iliac vein compression. I hear about this every meeting I go to. We haven't started using that in my own vascular lab. I don't know if you guys are using it for your studies as well, but maybe it's something that we'll be able to get validated in the future. But as of now, iliac vein studies to diagnose May Turners doesn't really exist. So for that reason, I think you need a different modality.
So I'm using a lot of iliac vein studies in my office. I started using it. I think it works very well. I think it can skip CT venogram for you guys. Again, there are a couple of ways of doing it. I don't think there's any right or wrong way. I mean, some of them are, of course, right and wrong, but I think CT venogram and IVUS is still the gold standard. I think it still stands to be the gold standard, because CT venogram can miss May Turners sometimes. But I think I agree with Hani. It depends on how good of an ultrasound technician you have with you. If you really trust your technician and if you're very good with your ultrasound skills, I think endovascular becomes really good, especially with ultrasound. I think if you guys don't have much of an ultrasound training, I would recommend definitely you can spend a couple of months in a vascular lab getting complete ultrasound training. Even if you want to do it yourself, it's not a bad idea, because if you start getting pedal accesses or vein accesses or anything, then it'll really help you a lot.
It's particularly important because you guys will be hiring people for your vascular lab. You have to know who's good and who's bad,
Yeah.
right? Like, so the importance of being there when they're doing their first couple studies and seeing how they are and helping them work through the protocol is unbelievably important. So, and there's no such thing as like this person is a bad ultrasound tech. That's someone that you need to work with and get them better and get them a better protocol.
That's
So
what
I
it
think
is.
it's important for you as a physician to know what you're doing as well.
Right. Any more questions? Good.
All right.